In this module, we'll be talking about nursing care of antepartum bleeding and premature labor. It should be noted that bleeding at any time during pregnancy calls for some type of evaluation. And we can break antepartum bleeding down into early antepartum bleeding and late antepartum bleeding. And we'll talk about these different types of bleeding throughout this module. Bleeding in pregnancy occurs about 50% of the time. Of that 50%, about half of those may result in pregnancy loss, and that's usually happening in the early antepartum period. Spotting is not uncommon in the first trimester, and it's usually related to implantation. So when the fertilized egg implants into that rich, thick endometrial lining, a woman may notice some spotting. Also, after intercourse, because the cervix may be sensitive, it's highly vascular, and with some exercise, she may notice spotting. So, but again, anytime a woman is bleeding during pregnancy or having any vaginal discharge, it should be assessed. The first type of early antepartum bleeding we'll talk about is abortion, also known as miscarriage. Should be noted that there are two types of abortions. There is spontaneous abortion, where there is a loss of pregnancy before the fetus is viable. So before 20 weeks gestation or 500 grams in weight. And these spontaneous losses is what we usually consider miscarriages. And most of the times, the unfortunate thing is that we don't know the exact cause of the miscarriage or the abortion. It could be related to chromosomal abnormalities, teratogenic drugs, endometrial abnormalities, infections, or a weak cervix. The other type of abortion is induced. And then there's under that category of induced, there's two subcategories. Elective induction is what we are more familiar with when we use the term abortion. So this is when a woman elects to terminate the pregnancy. Again, state laws vary on how far in the gestation or how far along in the pregnancy a woman can electively terminate the pregnancy. And then there are medically induced abortions, in which that there is medically the fetus is incompatible with life. It may have some abnormalities that once it's born, it's not going to survive, or that there may be a risk to the mother's health in which she could die if the pregnancy is continued. So there's spontaneous and then there's induced. And what we do know from spontaneous is that there's several causes, and oftentimes we don't know the reason why. There are 6 classifications of spontaneous abortions or types of bleeding associated with those abortions, and I'll talk about the 3 highlighted in red. A threatened abortion, again, is early in the pregnancy, usually in that first trimester, and it may or may not lead to a pregnancy loss. A woman may report that she's having some spotting or some bleeding, and so she would be evaluated through diagnostic testing an ultrasound to see if there is a fetus and that there is a heartbeat, checking of the placenta, seeing the location of the placenta, and then checking HCG levels. Because if you recall early when we were talking about the presumptive, positive, and probable signs of pregnancy, we talked about HCG, which is a hormone that increases and doubles early in the pregnancy, and then it peaks and plateaus. And so if a woman is presenting and we think she has a threatened AB, we would first draw a baseline HCG, have her repeat that in a couple of days, and we should see those numbers doubling. If the numbers are going down, then we've moved from threatened AB to an inevitable AB. So a threatened AB, again, may or may not lead to pregnancy, but there's some bleeding that could threaten the pregnancy. So inevitable abortion, and I use the term initials AB for abortion, is when a loss of pregnancy is going to occur. So this is that woman who was bleeding and the HCG levels are decreasing, or that we don't see a fetal heart beat any longer on an ultrasound. And so we want to monitor the physical signs and symptoms, assess her pain, monitor blood loss, but more importantly, we want to provide some emotional support, knowing that this could be a grieving process for some families. And so we want to make sure that we take care of the whole person and not just, again, focus on the physical. With an inevitable AB, a DNC, which is the dilatation and cortage, which means where we would dilate the cervix and then remove the remaining products of conception, may be an option for some women. Other women may choose to allow the body to dispel the loss on its own. And so it's provider preference on how long they allow this to take place, because again, you don't want to increase the woman's chances of infection. And so they would monitor her for bleeding and again do serial HCG levels until they're back down to a non-pregnant level. A complete AB or complete abortion is when the products of conception, and that's the medical term that we use, have all been delivered spontaneously. So on an ultrasound, there is no sac, there's no signs of pregnancy. All products have been dispelled. And so this often happens quickly. And after the complete removal of products of conception, the bleeding and pain will resolve quickly. And so again, when a woman may call and say that she's passed a large clot or what looks like tissue, you would have her come in immediately to be seen, if at all possible, to bring the clot or the tissues in a bag, in a Ziploc bag or so, that it may be sent down to pathology to confirm that it is products of conception, and again would want to do an ultrasound and HCG level to make sure that we haven't missed any products of conception, that there isn't anything left. So when assessing if a client is having or experiencing some type of spontaneous abortion, it's important that we as the nurses ask the right questions. They will oftentimes call into the office or to the hospital, and then you're going to be the first person they speak to. For the most part, you're going to do the triage, and patients may complain of cramping, some backache, um, some bleeding, and it can range from spotting or noticing blood on the tissue when they wipe to bleeding that looks more like a light or heavy period. It may also, again, like I said, in complete abortion, they may say that they've passed what looks like tissue or a large blood clot. And so when we're triaging and asking women questions, we want to know, one, do they know their gestational age? How many weeks are you? Because then that lets us know, is this an early antepartum bleeding or is this late antepartum bleeding? So if we're in the first and second trimester, if we're before 20 weeks gestation, we know it's early antepartum bleeding. How much bleeding would they describe that they're having? Again, is it a large amount? Are you soaking a pad? Do you need to put a pad on? Is it more when you wipe that you notice it? What color is the blood or the discharge? Is it bright red bleeding, which would signify an acute bleed, or is it darker brown, rusty color, which would could indicate to us that that's an old bleed, that this is old blood that is being discharged? How long have they been bleeding? Is another question that you would want to know. And have you had intercourse, or what were you or are you doing when you notice that you're having some bleeding? So again, asking those important questions can again trigger and signal to us what type of bleeding, if this is a spontaneous loss, threatened, inevitable, complete, incomplete, etc. Management of spontaneous abortions, again, one of the keys, I should say, is providing that emotional support. Of course, pain management and observing for risk of infections, if there's um, any fever, things like that, that we would then need to treat for infection. So here I've listed some basic management that healthcare providers would need to do for a woman who has had or is experiencing a spontaneous loss. And so again, for nursing, emotional support and helping with relieving of pain. Another topic or cause of early pregnancy bleeding could be an ectopic pregnancy. An ectopic comes from the word ectopos, meaning out of place. And so when we talk about an ectopic pregnancy, it is a pregnancy or a fertilized egg that has implanted outside of a site other than the endometrial walls. So remember, the uterus is the only muscle organ that is designed for pregnancy because it has the ability to expand to accommodate the growing fetus. There's no other organ or structure in the body that can support a pregnancy. And so again, ectopic pregnancy is the implantation of a fertilized egg outside of the endometrial cavity. And this occurs about 1 in every 50 pregnancies. And the most common site for this abnormal implantation is in the fallopian tubes. And so if you recall the journey of the mature ovum, from that's released from the ovaries, and that it's taken up by the finger-like projections from the tube, and sperm, it travels, that ascends up through the vagina, past the cervix, through the uterus, meets that mature egg in the tube, and that is where fertilization takes place. After egg is fertilized, then it moves down into the uterus and implants into the endometrial lining. So the journey of that fertilized egg is halted for whatever reason in the fallopian tube. And so as this embryo tries to grow and develop, it starts to draw blood from the site of implantation. So if it implants into the tubes, it's going to draw blood from that site, creating potential for the tube to rupture. So women who are at high risk for ectopic pregnancy include those who've had some type of tubal damage or scarring. So women who've had pelvic inflammatory disease, any surgeries, endometriosis, any structural anomalies to the tubes where they have narrow tubes, there's some blocking of tubes. And so women can present with some bleeding, some spotting. They'll have right shoulder pain is a cardinal sign. If you have a woman who has a positive pregnancy test who's complaining of right shoulder pain, this is referred pain, and it could signal that there's some peritoneal bleeding, that something has, a tube has ruptured. And so she may have lightheadedness and may show signs of shock if she has, if the tube has actually ruptured and she's having some bleeding. If the diagnosis of ectopic pregnancy has been found, there is a couple of ways to manage this ectopic pregnancy. So again, this is going to end in a loss because again, the uterus is the only place where a fertilized egg can develop and grow. Can't deliver outside of the uterus. So there's medical management and surgical management for ectopic pregnancies. And medical management is only appropriate if the tube is intact. So if the woman has not had a rupture, we can use methotrexate. And so if you're familiar with chemo drugs, methotrexate is a chemo drug, an anti-neoplastic medication. And so its use for ectopic pregnancy is what we call black label, meaning that it's not FDA approved, but ACOG, the American Colleges of Obstetricians and Gynecologists, do endorse this use of methotrexate. So a woman would be given this med, and it acts as a folic acid antagonist. And what that does is inhibit, or it stops, cell division. So there is no rapid cell division, which occurs as the fertilized egg starts to form into an embryo. So methotrexate stops that process, and then once those cells no longer are dividing, then it dissolves and it's expelled and reabsorbed through the body. So while a woman is taking methotrexate, we do need to monitor for signs and symptoms that that tube has not ruptured. Because if there is rupture, then immediate surgery is needed. So if she's having some vaginal bleeding, with some abdominal pain, if she's dizzy or lightheaded, we would want to get an ultrasound and make sure that she hasn't ruptured. And so if there is a rupture, or if the woman opts for surgical removal of this ectopic pregnancy, it can be done through a laparotomy, or a procedure in which the tube, the area where the implantation has happened, is removed, and there's a resection of that fallopian tube. Another cause or potential cause of early pregnancy bleeding is a disease called gestational trophoblastic disease, GTD. And this is, less common than ectopic pregnancies or spontaneous losses, in which the 1 in every 1,500 pregnancy results in a GTD. And this is a group of rare tumors that involve abnormal growth cells inside the uterus. And so it's a disease of the chorion and the trophoblastic cells growing and forming an invasive tumor. And there's two types of GTDs, a molar pregnancy, which is more common, and then there is a choriocarcinoma, which is a malignant form of GTD, where women would have to go through chemo and things like that. So I've attached here a link that discusses in detail gestational trophoblastic diseases. And what you want to, note is that the woman will have signs and symptoms of pregnancy. So she will have amenorrhea. She may have some spotting or some bleeding, but she would have a positive HCG, because the pregnancy, the body believes that it's pregnant, and so there is this development of a trophoblast and chorion, so starting the development of a placenta, and so she would have a positive test. But when you do an ultrasound, you're going to see grape-like vesicles in that sac, and there will be no fetal development, no fetal heart rate. Here I've listed signs and symptoms of a molar pregnancy. Again, it's always before 18 weeks gestation, so again in that early antepartum period. And here you note the color of the bleeding. It's old, it's brownish, it's rust color, and so again, that's why it's important to ask the right questions. There again, no fetal heart tones. If a woman is passing these grape-like clusters, and they're very bloody, and so again, a woman would most likely need a D&C to remove this molar pregnancy. And then I just put on the side management of the choriocarcinoma, which is less likely than the non-cancerous molar pregnancy. Now we're going to talk about late antepartum bleeding, including causes such as preterm labor and delivery, placenta previa, and placental abruption. Preterm labor is the onset of labor occurring before 37 weeks gestation. So anywhere from that 21 weeks to 36 weeks and 6 days, if a woman goes into labor, it's considered preterm labor. If she delivers within that time frame, it's considered preterm delivery. And so the longer she is, the later she is in that window, the greater the viability or the outcomes for that newborn. So if a woman delivers, if she goes into labor at 23 weeks and she ends up delivering, then the likelihood of survival is less when compared to a woman who goes into labor at 35 weeks and delivers. So anywhere within that time is considered preterm labor, and if she delivers, preterm delivery. Prior to 20 weeks or at 20 weeks and less, if there is a delivery, it's considered a miscarriage, or medically we call it an abortion. So about 12% of pregnancies result in preterm delivery in the U.S. And noting that there are disparities within the U.S. with African American women having even higher rates of preterm labor and delivery when compared to Hispanic women and Caucasian women. So here I gave provided just a visual of preterm birth rates and grades by state sources, the March of Dimes. And so as you can see that southern states and Puerto Rico have high rates of preterm births. And if you look geographically or racially, those states have high populations of low income African American women, with the exception of Puerto Rico. And preterm birth accounts for about 75% of perinatal mortality. Again, because we know that preterm labor that leads to preterm birth, resulting in a preterm infant, come with high risk survival. So they have issues with respirations, they have issues with cardiac, they have multiple issues the earlier they're born compared to being born at term. There are multiple risk factors for preterm labor that put women at risk for preterm labor. There are social factors. We talked about low socioeconomic status, which could lead to poor nutrition, poor prenatal care, substance abuse, stress, physical work. We know that, again, racial disparities. If you're African American, you have a higher risk of preterm labor, and there's various theories out there as to why that happens. Medically, an incompetent cervix, which we'll talk about, maternal infections. So again, sexually transmitted infections can increase a woman's risk for preterm labor. Bacterial vaginosis, if you recall, has had some direct correlation with preterm labor. Women who've had cervical surgery, so if they've had the HPV virus noted on their cervix and they, during their non-pregnant time on a pap smear, they may have had procedures done on the cervix, which could make it less effective. Women who rupture early, that's what PROM is, premature rupture of membranes. If a woman has multiple gestations, so women who have twins or triplets are at increased risk of not carrying the pregnancy to term. And if a woman has had a history of preterm labor or preterm delivery, she's at increased risk the subsequent pregnancies for the same thing happening. And so with all these risk factors that we know, still about half of preterm labor happens to women with no identified risk factors. So when we do know that there are some risk factors, we can be aware, but just know that when there are women who may present healthy who still may develop preterm labor and preterm delivery. Here again, I just put a little FYI chart here from a source. It's, it's a little old, but the risk factors haven't changed much. Um, Showing you odds ratio for these risk factors, odds ratio of a woman going into spontaneous delivery. So how do we manage a patient who's at high risk, not a patient who has or who is in preterm labor, but someone who's at the initial visit, we've determined that she's at risk for potentially going into preterm labor and delivering preterm. We'd want to discuss activity reduction as she furthers into the pregnancy. May want her to have some restrictions. May want to restrain from sexual intercourse because orgasms or seminal fluid can contain prostaglandins, which can stimulate the uterus to contract. Teaching the woman what a contraction may feel like, how to palpate, how to touch her abdomen to note if it's getting hard. She may have some home health visits by a home health care nurse. A case manager may be involved. Discussing smoking cessation programs because smoking can increase the risk of preterm labor and delivery as well. Want to provide support, stress reduction, so just general things like that to discuss with a woman to talk about anticipatory guidance for a woman who's at risk for preterm labor. So if we have a woman who we've identified is at high risk for preterm labor, there are some testing things that we can do that are strong predictors of preterm delivery. If a woman has a shortened cervix, which we measure during a transvaginal ultrasound in which we use a probe inserted through the vagina to actually measure the length of the cervix. So again, going back into your picture, your anatomy picture of the cervix, is that it is a structure that has an internal os opening and an external. So there is a length of the cervix, and that during labor it shortens and then it thins out and it dilates. We can also look at cervical vaginal fibronectin, and this is, vaginal secretions that we check that are only present during certain times, and I'll talk about how to conduct a fetal fibronectin test. Again, if a woman has had previous preterm delivery, and if she has a current infection, particularly bacterial vaginosis. So one of these strong predictors is a term that I do not like, incompetent cervix. To me, that just has negative connotation to a woman if you tell her cervix is incompetent. So whenever you use the word incompetent, it to me doesn't have a positive connotation. But that's the term we use. Incompetent cervix is when a woman's cervix prematurely dilates, and the cervix is shortened, and usually happens around 16 or 20 weeks gestation that this cervical shortening is noted. It doesn't happen often. Usually women who've had some surgery or some cervical trauma to their cervix, women who've been exposed to this synthetic estrogen called DES that was given to their mothers during the 50s and 70s. The children of these women are now experiencing cervical insufficiencies. Okay, and so the woman's cervix is dilating and she doesn't know it. So it's generally painless in that the woman presents with a feeling of fullness in the pelvic area or pelvic pressure, and upon an exam, the provider would see that the cervix, up on a speculum exam, the provider could see that the cervix is indeed dilating, and we may even see, the bag of waters, the amniotic sac protruding out of this dilating cervix. So in an effort to try to support this incompetent cervix, a provider could place what we call a cerclage, and the cerclage is basically that's a stitch on the cervix, trying to keep the cervix closed. And so cerclages are usually placed about 14 to 15 weeks. Again, after doing an assessment, and a woman may say she had a history of preterm delivery, or that she's been told that she has an incompetent cervix, that a cerclage may be offered. Here I've listed prior to the procedure, you want to do any type of cultures, you want to do screening for any types of infections, and then you want to have the woman in Trendelenburg position, which her head is down and her legs are elevated. So her legs are, and this is a extreme version of almost like being on standing on your head, basically, and because you want to get the pressure off of that cervix, pressure of the uterus off of the cervix. And then if the stitch holds, it's usually cut around 36, 37 weeks. Again, 37 weeks is term, and it has a high success rate of anywhere between 80 to 90% of success with a cerclage. There are women who what we call break through the cerclage, and that they continue to contract and the cervix continues to dilate, but there is a high percent of success. And so the woman may have some cramping after the procedure, and then you always want to talk with her for the remainder of the pregnancy about signs and symptoms of preterm labor. Here I've listed some general signs and symptoms of preterm labor, and again, some women may not experience any of them, some may experience all of them, but a woman would complain of having menstrual-like contractions or cramping, and it's been going on for some hours now. She may also complain of some vaginal discharge. Again, you want to ask the right questions to describe the discharge. Does it look like water, which could indicate premature rupture of membranes? Is it bloody? So you want to ask and investigate into the chief complaints that she may present with. And so again, it's important to ask the right questions. This is part of a nursing process. It's part of the assessment. And so a woman calls and complaints of some of the signs and symptoms on the previous slide. And so some questions you want to know: is the baby moving around? We want to know, is there active fetal movement? How often are you feeling these contractions? Describe them. Is it a constant pain? Does it come and go? If it comes and goes, how long does it last? How long is it between one contraction and the next? Is there any bleeding? Is there any, again, describe that vaginal discharge. Is there any signs of rupture of membranes? If she describes it like menstrual cramp, ask if she's eaten or drink anything water. Again, the uterus is a muscle, and that if it's dehydrated, it can cramp. And so you want to make sure that, she's been hydrated, and that it's not cramping versus true contractions. And so on the other side of this PowerPoint, I have some strategies and advice that you can give the client after you've assessed what she's presenting with or what she's calling and complaining of. It is important to know that the diagnosis, not the screening, the diagnosis of preterm labor is that there has to be cervical change happening less than 37 weeks gestation. So a woman has to have made some cervical change and has to be less than 37 weeks. So in that window of 21 weeks to 36 weeks and 6 days, there has to be some progressive cervical change. So how do we know that? So if a woman is complaining of contractions or cramping, and she's eaten, she's well hydrated, we have her come in, and you want to make sure she's not doing any bleeding, she's not, that there's no suspecting of rupture of membranes. If that's the case, then we'd want to have a visual look inside the vagina at the cervix through a speculum exam. If there is no bleeding, if there is no rupture of membranes, we can do a digital vaginal exam. And what we're checking for is we're checking for dilation. So if a woman comes in and she says that she's cramping or she's having some contractions, and we check her cervix and her cervix is 1 centimeter, well, we don't know if that's her baseline or not, especially if she's had more than one child. So she can always be 1 centimeter. So what we would do is monitor the woman for an hour or two, and then we recheck her. If she's now 3 centimeters, that's a progressive cervical change. And so we could then make the diagnosis that she's in preterm labor. If in a couple of hours, even though she's still cramping and contracting, she's still 1 centimeter, that's not a diagnosis of preterm labor. She can be having preterm contractions, but those contractions aren't making cervical change. And so cervical change is the key in talking about labor. Labor has to have cervical change. Even if she's ruptured, she's not in preterm labor. She has premature rupture of membranes. Her membranes, her bag of waters has ruptured prematurely because she's less than 37 weeks. So hopefully that's clear. If it's not, please let me know and I can explain it again, or you can tell me what isn't clear. But preterm labor, the diagnosis of it has to be progressive cervical change. So we talked about predictors of preterm labor. And so I had on that slide fetal fibronectin testing. So fibronectin is this glycoprotein that's produced by the placenta. So basically, if you think about it, it's the glue that attaches that fetal sac to the uterine lining. So the glue that attaches the placenta to the lining. And it's present in cervical vaginal secretions up to 22 weeks. And then we don't see that those secretions again until labor is approaching. And so if there's a woman who has a high risk for preterm labor, after that 22 weeks, 24 weeks, 28 weeks, somewhere around there, we can do a fetal fibronectin test. And so it would be set up like a pap smear, and where there's a speculum inserted, and we take samples, a swab, and swab the cervix. If that test comes back negative, meaning that there is a low value or no fibronectin noted, it's highly predictive that preterm labor will not occur. However, because if a test comes back positive showing that there is some fetal fibronectin, we cannot use it to predict that preterm delivery is likely. So I know that's a little bit confusing, but fetal fibronectin test tells us that labor will not occur. It doesn't tell us that preterm labor or delivery is imminent, or that it's positively going to occur. So it can occur with a positive reading, or it may not occur. But we know that if we do that test and there is no, if that glycoprotein isn't present, that's more predictive that preterm labor will not occur. So we use that as an assessment to tell us that this woman's not at risk, or that preterm labor is not imminent. Now we have the woman who thinks that she may have ruptured, or she complains of a watery vaginal discharge. And so we want to check for rupture of membranes. And so again, if there is not a large gush of fluid obviously noted when you see her, then we're going to do a speculum exam, and we're looking for pooling of any fluid in the vagina. And again, we take a fox swab or a Q-tip, and we take a sample of that fluid, and we can do two tests. We can rub that fluid on a clean slide, and we look under the microscope, and we would see ferning. So like the picture you see there, and it looks like fern leaves. All right, so if we see ferning, that is the presence of amniotic fluid. Or we can use amniotic paper, and it looks, we call it nitrazine paper, and it looks just like pH paper. And if we swab the vaginal area and we rub that swab on that paper, it turns Marquette blue. So it turns blue. The thing with the nitrazine paper is that semen can also turn the paper blue. And so we use the ferning as a diagnostic test. And then you can also ask for an order for an ultrasound, and the primary care provider can perform an ultrasound to test the amniotic fluid levels. And so just note that you as the RN can obtain a fetal fibronectin, do the cultures for chlamydia, gonorrhea, and to do a wet mount to rule out bacterial vaginosis, which can be, and also another reason why she's having vaginal discharge. Here I've listed a couple of various modalities to try to decrease a woman's risk of preterm labor. None of these are 100% effective, but using them in combination can decrease a woman's risk of preterm labor, especially if she's been identified as high risk. So the goal of preterm labor management is to detect those who are at risk, early detection of signs and symptoms of preterm labor, so that we can start to focus on tocolytic drugs to try to prevent preterm delivery, because we know that preterm delivery decreases positive neonatal outcomes, because it increases the rates of preterm birth, and preterm babies have high mortality and morbidity rates. And so the focus is on short-term administration of tocolytic drugs. And these drugs allow us time um, mainly to administer corticosteroids that help improve neonatal outcomes. And I'll talk about these steroids in the next slide. So corticosteroids, in particular betamethasone, is what you will most likely see, helps to accelerate fetal lung maturation. So it helps with the development of surfactant, which is needed in order for the lungs not to collapse when the baby breathes. And so we know that surfactant isn't fully developed until around 35 weeks gestation. And so if we have babies that are women who are experiencing preterm labor and they are not at least 35 weeks, we want to get that, give us time to get this corticosteroid on board to help increase the chances of that lung maturation. And so we give drugs, tocolytic drugs, which I'll talk about, so that we have time to administer these 2 doses of betamethasone, usually 12 milligrams IM, 24 hours apart. So we're trying to basically buy time so that we can get this baby in, stay in longer, and to increase the likelihood of that lung maturation so that surfactant can be developed to help with lungs. In addition to buying time to administer this corticosteroid, we want to we want to also do a group beta strep culture, or if there isn't time, to just treat the woman for GBS, which is group beta strep, because we know that this bacteria found in the vagina is not harmful to women, but can be harmful to the newborn if delivered through the vaginal canal. So we want to treat the woman prophylactically with penicillin, preferably, and get a couple of doses of that on board as well. So these tocolytic drugs that I'll talk about in the next slide buys us time to do these 2 things, to put some steroids on board and to prophylactically treat a woman for group beta strep if we do not already know her status. So what are these tocolytics that I talk about? These, again, are not a cure for preterm labor, but the hope is that they delay labor for a couple of days, even up to a week or so. And what they do is promote uterine relaxation, because the uterus is contracting. So we want something to help slow or calm that uterus down. And so you see 2 drugs highlighted here. Our friend magnesium sulfate, which we talked about for the treatment for preeclampsia, mild to severe preeclampsia, as a CNS suppressant to increase the seizure threshold. But here in preterm labor, we're using magnesium sulfate because it's a muscle, it promotes uterine relaxation. And so we give magnesium sulfate, and we talked about that. The other drug that could also be used, terbutaline. If a woman is having some contractions, a provider may start with an IM injection of terbutaline. And there is a black box warning against the use of terbutaline for prolonged use for preterm labor because it has cardiovascular side effects. And so if we're trying to withhold or trying to prolong this pregnancy, magnesium sulfate would be the drug of choice as opposed to terbutaline, because there's a warning against prolonged use of it. But just know that those are two drugs that you may see in the field, magnesium sulfate and terbutaline. So here I just go into another, some more detail about beta mimetics. So beta 2s like magnesium sulfate, again, relaxes smooth muscles, and then beta 1 receptors do the same, but here I list some of that cardiac concern regarding meds such as terbutaline. So increases heart rate, shakiness. So, you want to, prior to giving terbutaline, you want to check a woman's pulse and get her resting pulse rate. And then you want to monitor her after you've given that terbutaline as well. So now that we have a woman who's on a tocolytic drug, let's just keep it with magnesium sulfate. What is the nursing responsibilities? Again, she's going to be in-house. She's in the hospital, so there's an IV going. We're going to continue to monitor vital signs, fetal heart tracings or fetal heart tones. We want to be aware of. She's going to be resting, preferably on her left side. Again, we don't want her lying supine. There may be other orders for lab work and cultures, group beta strep cultures if there's time, and we want to continue to provide emotional support. So because of knowing what's happening preterm labor and not having a baby come to term and being afraid of what the unknown is, or anticipation of complications with a preemie, we want to make sure that we bring all appropriate providers on board during this time. So if she needs to talk to the NICU, if there's a social worker who needs to come in and discuss what's going to happen after delivery, if we want to involve family in the care, because if this woman's in hospital for on bed rest for some days on the medication, she needs family or support persons close by. And so again, we want to take care of the whole person, not just the physical. Another late cause of bleeding late in pregnancy is what we call placenta previa. So placenta previa is a condition in where the placenta is lying near, partially, or completely over the cervix. And this is not normally where we want the placenta to lie. We want the placenta to be up farther, closer to the fundus, to the top of the uterus, not low lying near the cervix, because we don't want the placenta to deliver prior to the fetus. If the placenta delivers prior to the baby, then the blood supply, or the source of nourishment to the fetus, has now been delivered prior to the baby. And so when a placenta is lying close or near the os, a woman could be at risk for vaginal bleeding. And so placenta previa, even though diagnosed early on in the pregnancy, so around that 20-week ultrasound, the doc or midwife may note that the placenta is they'll note the location of the placenta. And so placenta previa can be classified as total previa, meaning that the placenta is covering the cervical os, that internal os. It can be partial, where half of it is covering the os. Marginal, where a smaller portion of the placenta is covering the cervix. And then it could just be lying low, that it's not touching the cervix, but it's lying lower in the lower segment of the uterus and not in the upper fundus area. And so if a woman has a diagnosis of placenta previa, particularly if it's partial or total placenta previa, she will probably have multiple ultrasounds throughout the pregnancy, just again to note that location of the placenta. Um, in the second and third trimester, if a woman has been diagnosed with a placenta previa, if she has bleeding, it's going to be painless bleeding, meaning that she's not going to have any contractions. She's just going to note that there's some bleeding. It may be spotting, it may be light bleeding, it may be heavier bleeding, and it's going to be bright red. So it's going to be fresh, what we call fresh blood, bright red bleeding. So if she has painless, bright red bleeding, one of your differential diagnoses would be placenta previa. If a woman presents with bleeding, bright red bleeding, no one should be doing a vaginal exam. We should do an ultrasound should be ordered, or she may even have a speculum exam. We should monitor fetal heart tones if there's bleeding. This is second, third trimester, so this is late pregnancy, so we want to monitor fetal heart rates, and we want to get this woman assessed. So placenta previa is painless, bright red bleeding, and we do not want to put our fingers in the vagina if a woman is having some bleeding. Placental abruption, on the other hand, is more common in the third trimester, and it is the premature separation of a normally implanted placenta. So that placenta is in the upper region of the uterus in the fundal area, and there's a premature separation of that. It can result from trauma. If a woman is in a car accident or there's some abuse going on and she's had any abdominal trauma, that could put her at risk for the placental abrupting, meaning tearing away from the uterus. It can happen related to preeclampsia. With the constriction, vasoconstriction can cause the premature separation of the placenta. And this woman will note painful. Her uterus will become hard and rigid, so it's like pressing into a wall. You can't indent it. And so she's going to complain of pain, a rigid abdomen, and she may have dark red bleeding because that blood, as the placenta separates, can be concealed in between the placenta and the uterus. And so as it separates, by the time it reaches the vaginal area and comes through the external os of the cervix, it's dark red, it's old blood. And so painful, rigid abdomen with or without some bleeding, and if there is bleeding, it's dark red, would signal a placenta abruption. And so this is more emergent because as the placenta's tearing away, again, we think about utero-placental insufficiency. This placenta is not going to be able to sufficiently support or nourish this fetus. So oxygen is going to be decreased. The blood supply is decreasing. So this baby needs to be delivered ASAP. If this woman is having this bleeding, she's at risk for hemorrhaging, and she's gonna at risk for shock. And so we want to look that there would probably be rapid changes in her vital signs, her pulse and blood pressure. And so again, we want to move quickly with a woman who is abrupting, and she is going to have a cesarean section. If a woman has a placenta previa and it's a complete previa or a partial previa, she too would be a candidate for a cesarean, because again, we do not want the placenta delivering prior to the baby. And in a placental abruption, the concern is twofold. One, for the mother, that she can be going into shock, and two, for the for the fetus, because now its supply is insufficient. Here I've listed the grades of placental abruption and the signs and symptoms you'd see. So the higher the grade, the more severe and the quicker delivery needs to happen. And where we're at a grade 3, most likely the fetus is dead because there's been complete detachment of the placenta, and the woman is in shock. And so we want to catch placenta abruption early in grade 1. When we have women complaining of a sustained, painful, tight, hard uterus, we want them in to be seen ASAP. Another reason or cause of placental abruption is women who have had cocaine. Cocaine can cause an acute placental abruption, and so again, you want to be cautious and aware of your clients. Here I just did, this should be just review on how to manage shock, and I use the acronym ORDER. So again, just know that you're preparing for emergency delivery when you're dealing with a woman who is abrupting. And then in the postpartum period, we want to again monitor for hemorrhage. Is she going to be anemic? And if it's true shock, organ failure such as renal damage. Here, complications associated with placenta abruption or abruptio placenta. DIC is common. She's going to deliver. A woman may deliver precipitous. So if a woman delivers very quickly, the uterus may just come with the baby. In the postpartum period, she is at risk for PPH, which is postpartum hemorrhage, because the uterus is not able to contract and stop the bleeding. There's infant mortality and maternal morbidity and mortality that we should be aware of, that the woman is at risk as well. And here again, this is just for review, just to give you a refresher on signs and symptoms and management of DIC. Again, not for test purposes, don't need to focus on it, but just know that it is a complication, potential complication of placenta abruption. And so in this module, we've talked about bleeding in early in pregnancy, late in pregnancy, and also talked about preterm labor and preterm delivery, assessments, signs and symptoms, who's at risk, and nursing management for these conditions. As always, if there's questions or concerns, please feel free to contact me.